All right, everybody, welcome back to Psychiatric News Special Report for the month of June. We have a wonderful article as we go into the summertime, clinical considerations of cannabis use in the inpatient medical setting. I'm your host, Dr. Sulman Aziz Mirza, triple board certified adult psychiatry, child adolescent psychiatry, and addiction medicine. So this is going to be a fun one. I think it's something I get to put on my addiction medicine hat and then partly my child adolescent hat and then the adult one as well, because we're seeing this in all settings. And I think it's something as we progress in 2026 and, substance use and especially cannabis use is becoming more and more prevalent. We all have to become just more aware of how this shows up in our world. So let's introduce our guest. Welcome our guest, Dr. Heather Murray from University of Colorado. I'll let her introduce herself, her bio, background, and her blah, blah, blah.
Hi, thanks for having me today. I'm excited to be here. So, again, my name is Heather Murray. I am a CL psychiatrist at the University of Colorado Hospital and CU Medicine Psychiatry Department in Aurora, Colorado. I did medical school at Emory, have an MPH in epidemiology, and went to Denver for residency and my CL fellowship and haven't looked back.
Yeah, it's a wonderful place. I don't know how many people have a chance to go out to Denver, Colorado area. I did part of my going through the Caribbean Med School is they send you to rotations all over the country. And I did my
Right.
12 weeks of internal medicine in Colorado. And I was like, wow, this is earthy, crunchy, munchy Denver and Colorado. And it's just beautiful out here going up to the mountains. And so a wonderful, wonderful place. I encourage everybody to visit.
Yeah, it's fabulous. And I will say the people are so friendly here and the
Yeah.
food has gotten a lot better in the last 10 years
Yeah.
where things are looking up in terms of the spice level.
Yeah, it was bizarre. I was with a good group of people, and we were like, we need to find some Indian Pakistani food. And we found this
Mhm.
this wonderful Punjabi restaurant in Denver. I think it was India's Pearl. I think was the name of it, and it was fantastic. I was like, they have good Punjabi food over in Denver. This is bizarre, but we'll take it.
Yeah, I think a little known fact about the area, Aurora in
Yeah,
specifically, is
yeah.
it's one of the most diverse counties in the country.
Hmm.
We have refugees, immigrants from all over the world, and I think that just makes it such a special place and also has contributed to the food scene dramatically.
Which is always key for finding a place to settle down and live. So.
Yeah, exactly.
All right, awesome. One of the other unique things about Colorado is it was, I think, as we all kind of know, was the first state to really fully legalize. I think first state, right, to fully legalize cannabis, right? It was that or Washington?
Yeah, for
Yeah, yeah,
recreational use
recreational
in
use.
particular.
Yeah, so it's a unique spot to kind of get into this topic and where this kind of article is coming into. So, Dr. Murray, tell us a little bit about what made you focus on this specifically in the inpatient medical setting.
Yeah, so you've already actually alluded to a big part of my journey to this topic. So I moved to Denver, Colorado for my adult psychiatry residency training in 2012, which was the actual year that recreational cannabis was legalized here in Colorado. Because we were one of the first states with recreational use, anecdotally, I found that many of my patients moved here specifically because of the availability of cannabis. And during the following years, throughout residency, while a lot of patients reported improvement in quality of life with cannabis use, I found a similar amount would also mention struggling with escalating cannabis use, particularly of high potency formulations that we'll talk a ton about, and actually started to identify correlation between high potency cannabis use and adverse psychiatric and medical symptoms. I ended up doing my CL fellowship at Colorado as well, have been faculty at our large academic level one trauma center for the past 5 years. And during this time, the trend has only become more apparent. Because of our university's location in Colorado, our department has some excellent research and subject matter expertise in this area generally. And I've been lucky enough to have been working with a few people on different projects. But one thing I found throughout this work is that there's actually not a ton out there available for psychiatrists working in the acute medical care setting or within my specialty of CL psychiatry. So I wanted to contribute to the literature through my own discovery and education. So that's what led me to this article.
Yeah, it's definitely something we're seeing. Again, people who are doing a lot of clinical work, it's just a byproduct of what's out there and what people have access
Right.
to. I say it all the time when I'm working, especially with teens, and the parents bring the
Yeah.
teens into the office, and they're like, "Can you tell my child to like stop smoking weed?" And I'm like, "Well, it's not that simple, right?" And
Right.
a lot of times, one of the avenues I have to go to and discuss is, especially when parents are kind of like, well, it's just cannabis. If they're trying to
Mhm.
minimize it, or they're saying, well, at least, well, I'll be okay with them using that, is like, it's not, your daddy's cannabis nowadays, right?
Right. That's so funny. I always joke with patients. I say, well, it's not your mama's swag,
Yeah.
because it's so different from what it was back in even the 90s, early 2000s.
Yeah. And it's this idea, like, I think there's, again, then you have people who are going to come for, I want to say contra, but people who are, again, people online who will say things like, "Oh, it's natural and it's organic, and
Right.
as you should be able to like just use what's of the earth and blah blah blah." And it's like, I don't think there's such a thing as like natural and organic, like the original cannabis plant that exists anymore. It is like
Right.
become the most GMO plant out
Right.
there. It has become so modified, so crossbred and hybrided to become these high potency strains that are
Mhm.
out there. I was like, there's no such thing as like, again, natural organic cannabis anymore.
Exactly. And yeah, it's interesting because humans have had a relationship with cannabis for thousands of years. And that relationship, I think, has been culturally special to so many people. But the reality is that, like you mentioned, it has been bred to be higher and higher potency. And that's something that we'll definitely talk about in a lot of detail. But I think the potency piece is particularly important. And we can actually see a lot of analogies to that with, let's say, looking at opium coming into heroin and now fentanyl with kratom 7-OH, right? We're creating these really potent substances that actually have completely different mechanism of action and psychopharmacological properties in the brain and the body in particular. They're like a different drug.
Yeah, I mean, they are totally different drugs. Like, I think, like, you bring up the kratom thing with kratom as well, especially when you know that like low doses of kratom work as like a stimulant and higher doses work as
Right.
an opiate. And, I have plenty of people coming into my clinic who are trying to get off of opioids, and they're like, well, I don't want to do
Yeah.
Suboxone or buprenorphine, and I'd rather do kratom. And then they'll do that on their own. And then they will say, well, now I can't get off of the kratom, and now we have to go to the
Right.
buprenorphine, and it becomes this
Right.
back and forth ping ponging that occurs with it. So
And it's very expensive as
it's
well, both cannabis and kratom, so
yeah.
expensive.
Yeah, so it's not always like the best option for these
Yeah.
patients. So
But it's also understandable, right? How people end up there and they're doing the best thing in their perspective for their health, for their body. And so much of it, I think, does come down to, how we market it both as a specialty within medicine, but also more from a public perspective. That's really important as well.
yeah, let's talk about let's we're talking about the potency. So yeah, tell us about the potency shifts, and then that's
Yeah.
one of the things one of the topics of the article that really stands out. And I think something, if people are just either reading the article or listening to the podcast, like the I think that's the biggest takeaway, if nothing else.
Yeah, I agree. That actually has been my biggest takeaway through my own learning and research over the past few years on this topic is that, just because something is called cannabis doesn't mean it's the same drug as the other thing called cannabis. So, like I mentioned, it's been used for thousands of years. The plant itself actually consists of over 100 active compounds, including terpenoids, phytocannabinoids, flavonoids, cannabidiol, THC. So, THC is the chemical most implicated for psychiatric psychoactive effects of cannabis, while cannabidiol is thought to be largely protective against these effects. So, in the 1990s, when we measured the concentrations of THC in the average cannabis strain, it was about 4 to 5%. That was kind of as high as it would get. And then CBT is generally in lower concentration, around zero point 0.2 to 0.5%. However, most recently, and this is the case in Colorado, for example, I've gone to dispensaries to see what is the potencies that I can get. I couldn't find anything below 20% concentration of THC. So we're really breeding these cannabis strains now to have super high concentrations of THC while simultaneously we're not also increasing CBD or these other protective chemicals, right? So you end up with a ton of this psychoactive substance in super high potency. On top of that, so not only do we have the flower with this high concentration of 20 to 40, 50%, we now create these concentrates for recreational use. So, concentrates in general, you might hear them referred to as shard, oil, shatter, dabs, wax, and they can come in concentrations as high as 90 to 95% THC and can be either ingested or inhaled through vaporizers. So, pretty potent chemicals that really are very new over the last 15 years or so. And I think part of the issue is that the industry and the regulation are outpacing research and medical and psychiatric understanding of these substances, that it's hard for us to keep up as medical providers.
And with that, I mean, like, it's, it's ridiculous to see. And like, you're talking about 90 something, I've seen like 97%, I think.
Yeah,
It's just out of control. And it's like, we kind of lose sight of the fact that this is a substance that's going to negatively affect us,
right.
especially, like has been, if anything has kind of been like everyone talking around has been CBD is the good part of it and THC is the
Mhm.
bad part. And it's like, well, why are we increasing the THC concentrations while dropping the CBD concentrations in these plants and these substances? So it's like a little bit problematic, right?
Yeah, absolutely. And I think part of the issue too is tolerance. People develop tolerance and they're asking for higher and higher concentrations, which have these just catastrophic effects from a psychiatric perspective on occasion.
Yeah. Do you feel like clinicians are keeping this idea of like the cannabis is this like low potency substance, like they're just
Mhm.
holding on to this idea versus fully moving and understanding that like, oh no, it's a whole different thing than what it was, like you're saying 10 years ago, 15 years ago, 20 years ago and beyond.
Yeah, I have certainly noticed a shift in the understanding. I would say in the last, we probably were a little bit ahead in Colorado just because we had it recreationally earlier. I think especially the last 5 years, I'm starting to see that it's part of the main culture of medicine. It's the primary understanding, I think, in medical practice that cannabis has just changed as a substance. But again, that's 10 years after really the changes started happening. So it takes time. Anytime research happens in medicine, there's a delay in translation to practice, right? And there are a lot of cultural factors at play there. People kind of want to see studies replicated, see the evidence determined over and over again. But I think that the culture has now shifted in medicine where people are really starting to understand this change in cannabis.
Yeah. With for like inpatient docs, people who are inpatient psychiatric units or kind of like yourself, CL psychiatry,
Yeah.
what are people seeing? I guess what are clinicians missing with cannabis related complications? How do they show up within the inpatient setting, especially for like people who are daily users, the wake and bakers per se?
Right. Yeah, exactly. I think if I think about it from the perspective of someone who like starting with inpatient psychiatry or emergency psychiatry, right? So some of the most interesting experiences I had in emergency psychiatry here as a resident was seeing people coming to Colorado for cannabis tourism. And one of the effects, for example, were edibles. And so with edibles, it can take 90 minutes to 2 hours to start really feeling the effect of the cannabis. And that leads to people maybe after 30 minutes saying, oh, you know what? Maybe it's just not impacting me that much and ingesting more and more of it. Plus, they're cookies, candies, they taste good, right? And you don't understand how you're going to react to it. So I would see really profound panic attacks, anxiety. People would come in thinking that they had a pulmonary embolism, a heart attack. And it turns out it was, panic from cannabis intoxication, as well as psychotic symptoms, right? So delusions and paranoia in particular. And I know we'll go into a lot more detail about the evidence there, but I think intoxication itself can certainly cause psychosis with the paranoia in particular. And then you also notice some people have a lot of cognitive blunting, so issues with short term memory, spatial task, processing speed can be pretty remarkable. And then once someone actually gets admitted to the hospital, so let's say within like the first day or so, I think that we often underdiagnose or recognize cannabis withdrawal, which is a huge issue and has actually been associated associated with discharging against medical advice. And it's something that is treatable. And then on top of that, of course, it's, sort of differentiating in this young person, maybe with a family history of psychosis, who has started using cannabis with new onset psychotic symptoms that haven't resolved with intoxication. Is this actually a new schizophrenia, or is it more kind of a substance induced psychosis? And trying to parse it out in someone who can't, has a hard time abstaining from cannabis use for more than a week or two on the inpatient setting. And then on the medical side, certainly, considering diagnoses such as cannabis hyperemesis syndrome, could it be contributing to issues like encephalopathy or delirium, as well as catatonia? And I think one of the biases that I often see within myself and others is people of certain ages, oh, they wouldn't be using cannabis. But I think we have to remember kids find edibles, they think are gummies, they find brownies, cookies, they eat them. So kids can come in with cannabis intoxication. Older adults, too, they use cannabis and sometimes are more likely to become delirious with cannabis use than someone who's younger and healthier. So I think there's a lot actually to consider from the psychiatric perspective in cannabis use. And, the struggle is that it's so new with these high potency formulations. A lot of us weren't taught these things in medical school or residency. So we're having to learn it along the way, which can be really challenging.
Yeah, you touched on a lot there, so I was like, we'll try to break it up a
Yeah.
little bit, but I'll share kind of like a funny-ish story. So my uncle, he is dealing with some effects of a type of adenocarcinoma, a type of lung cancer,
Mm,
and he's like, he's fighting it. He's going. It's been a
yeah.
few years, and he's going. And one of
Wow.
I have a cousin, his daughter, who is like a cannabis pharmacist. So
Mm,
she makes like some suppositories for him. And then, whether it's, he knock on wood and say like, he should have been gone a couple of years ago normally. He's in his
yeah.
90s but he's chugging along and, my mom's doc and myself and everyone's like, he's going. And we don't know if these suppositories are doing something or not for him, but like he's going. But
Yeah.
the funny part is, or the story part is like, my cousin was making some stuff at home and was using like a bowl to kind of create the suppositories and, you know, kind of gave it a little rinse. Then later, my dad was over, my mom was over, somebody else was over, and they were making like breakfast omelets and they, you know, end up using the same
Oh,
bowl
no.
without giving it a
Yeah.
proper rinse. So my dad is, to my knowledge, has never used cannabis before. He's like 70 something years old. And, they eat the omelets. And I think one of my other cousins was over as well at the time. A few hours later, they start feeling ill and, they're like, what's going on? My cousin's like they get the emergency room or the ambulance comes over, takes them to the emergency room. It becomes a whole thing where like someone's having a panic attack. My dad is like, what's
Yeah.
going on? And again, like, you know, luckily it was just emergency room. Nobody got admitted, and they did the drug test and were like, "Oh, it's cannabis, and what's going on here?" And they were like, they're able to do detective work and find out what was going on. But and it's a funny story in the moment, but or in retrospect, a funny moment. But in the moment, everyone's kind of like freaking out and being like, "What's happening right now?"
Right, especially if you don't know that
Yeah,
that was what you were exposed to. It could be a
yeah,
number of things that are scary.
yeah. Yeah, especially like in someone who's like 70 something years old, naive
Right.
to it, it's like a whole situation. But
Yeah.
luckily all's well that ends well. But
Well,
you know,
I'm glad to hear your uncle is doing so well.
yeah. So yeah, it's a good thing. Um,
Yes.
so which is it's interesting, right? Because we talk a lot. I know in the preface of the article you talked about something about like this is kind of like we're focusing a little bit on the negatives, but there are potential
Mhm.
positives, right? So tell us a little bit about that. Like so
Yeah.
and we'll pivot a little bit for that. Like some of the positives that come from cannabis. What are some potential uses that we have? I think we all know. I think from medical school
Yeah.
at least, like you use it for like appetite and like chemotherapy
Mhm.
patients. But like aside from that, what else we got?
Yeah, so that's of course the main one. When you think about dronabinol, right, sort of our medical formulation of THC, it's FDA approved for both the nausea and vomiting related to chemotherapy, but as well as appetite for folks struggling with HIV, AIDS related illness. So those are two of the technical FDA approved indications. But there also is some data for other symptoms. So, for example, spasticity due to a variety of neurologic illnesses can be managed with cannabis. And we'll talk a little bit more about this, but even within psychiatry, I think with short term use, people do report improvement in things like REM sleep disordered behaviors, sleep onset, acute anxiety, and PTSD symptoms, though the long term results turn out to be not associated with improvement. But I think it's important that we recognize again, cannabis is very complex. Again, there are over 100 chemicals. And I think that we need to be really nuanced with our take on it. It's not all good, it's not all bad. It's complex, like most things in life, and most things, especially in psychiatry. And so I really appreciate that you asked that question because I think there are a lot of people who have found incredible quality of life improvement with cannabis related products, and I think it's important to validate that experience while simultaneously making sure that we're doing the due diligence of researching some of the other unintended consequences or negative adverse effects so that we can provide folks with a really balanced take of risks and benefits so they can make decisions that are best for them as individuals.
Yeah, it's one of those things I get into the conversation with, especially the teens, right? When they're like,
Yeah,
this is helping me for my anxiety. And it's like, oh, I'm not going to lie to you and say that it can't do that.
right.
it doesn't make, it's not genuine of me to kind of take that approach and say, well, no, you're wrong. Even though you're saying that it's helping your anxiety. I'm going to tell you that you're wrong. Like, no, I've lost the rapport already from day one if I start off with that
Yeah.
approach. So, it's something, yeah, like you're right. We have to kind of balance. It is nuance. Nuance isn't always sexy when we're trying to like get clicks and
Mhm.
headlines and all that stuff out there, but it's something that is, we have to understand that a lot of it comes with exposure and then dependence,
Yeah.
tolerance, all that comes along with the cannabis use as a whole.
Right. And I think actually another topic that is important and fairly recent is that for the first time, cannabis use has actually outpaced use of alcohol, especially with kind of more moderate usage. And younger generations are really replacing a lot of alcohol use with cannabis. And I think an argument can be made from like a harm reduction perspective in that sense, right? Because alcohol is not benign, despite the fact that it has been so ingrained in our culture and legal for so long.
Yeah.
So I think that, there are a lot of purposes of cannabis. So again, it's really about just making sure we have good understanding of these risks and benefits so we can really help counsel people.
Yeah. I always kind of like talk about that when I talk about like substance use and talks. I was like,
Mhm.
I'm always asked to like do the opioid talks and like the cannabis talks, but then
Right.
it's like we have to remember the alcohol is like it's on a whole different chart, whole different
Yeah.
level.
It's a killer.
yeah, it's terrible, and
Right.
we just kind of like assume that it's there, and then just be like we'll just throw our hands up and just say we can't do anything about it. It's like no,
Right.
it's we could do it, and then yes, it's great that like I get you pointed out that like the alcohol use has dropped while cannabis is kind of
Mhm.
like taken over that. So it's like again, is it the greatest thing? Maybe, maybe not. Who knows? But it's
Maybe
something that we're
from
seeing
harm,
from a harm reduction
right,
point of
harm
view. Yeah,
reduction, right.
absolutely. So
Yeah.
you talked also about like withdrawal. So talk to us about the cannabis
Mhm.
withdrawal because that's something that's interesting. I think people don't always understand it or underestimate it at times too.
Yeah, absolutely. So you're going to hear this theme over and over again, the increased potency, right? So I think of it as dosage. So 20 years ago, you would have to smoke so much weed to get the THC concentrations that you can get it with casual use today. And so with higher doses, your body is reaching homeostasis with regular usage, similar to regular alcohol use, right? And so if you abruptly stop that, say with a medical admission, for example, all of a sudden that substance is no longer in your brain. And often people will experience symptoms of cannabis withdrawal within about 24 hours of cessation. And so symptoms often will include things like irritability, anxiety, insomnia. They'll have difficulty with focusing and even somatic symptoms like nausea, tremors, or diaphoresis. It's really uncomfortable. I think part of the reason we overlook it is it's just not one of the withdrawal syndromes that leads to significant medical outcomes. And so it tends to be sort of minimized, right? Especially in the inpatient setting where we're really thinking about, okay, what is acutely going to harm this patient right now? However, because it has been associated in studies with self directed discharge of patients, it can indirectly lead to adverse medical outcomes, right? If someone's sitting there, similar to nicotine withdrawal, and we're not treating it, they're totally uncomfortable. They just want to get out of the hospital, not be there anymore. And they might actually not treat the medical cause that led them to the hospitalization in the first time, which could lead to worsening and bad outcomes.
Yeah, I think a lot of people underestimate the effect of like that withdrawal and that craving
Yeah.
for it. I've had, like when we had PHP where I was working, partial hospitalization program, and teens coming for that, like I've had patients eloping from the building, running into the streets literally just because of the nicotine and
Right.
cannabis withdrawals. And there's like people don't under they just don't realize that this is some of the effects of this is like people are it's really hard to just stop it and say like, no, you have to just not use it while you're here for these 6 hours a day.
Yeah, exactly. Like easy peasy,
Yeah.
right? And I think too, especially if you have underlying psychiatric conditions that you're sort of treating with these substances, let's say PTSD, for example, and now we take the substance away, we put you in this acute medical care setting where you have very minimal agency. People are touching you without your permission, bugging you all the time. You're already becoming irritable. You have hypervigilance symptoms, hyperarousal. It just can really exacerbate psychiatric symptoms in the hospital in particular.
So on that like level, what could hospitals do, inpatient teams, what can they do to kind of manage withdrawal, cannabis withdrawal, to prevent these
Yeah.
discharges, AMA discharges?
Yeah, I mean, I think that cannabis, screening should be a part of any medical and psychiatric screening interview on admission. Obviously, some people are too medically acute. Let's say after a car accident, they're admitted to a trauma surgical team. Oftentimes they do that sort of first initial trauma evaluation. And then once the patient's stabilized, they go back and do their second evaluation. The similar can be said for a lot of like our social and substance history in patients. So once the patient's more medically stable, go back and ask them these questions that are actually really important, particularly with substance use. And I think cannabis should always be included. And when we're evaluating cannabis use disorder, we're not just asking, like, hey, do you like smoke weed? You want to ask them questions like what formulation, if they know the THC concentrations, are they doing things like the high concentrates? Are they doing flower? Are they smoking? Are they ingesting, for example? So you want to know the formulation and the potency so you can have a better understanding of the dose. So, how frequently are they using it throughout the day as well is going to be really important. And then, of course, last time they used it. So, if they used it a couple weeks ago, I'm not worried about cannabis withdrawal. If they're using heavily daily and last use was yesterday and now they're feeling irritable, that might be the cause of it. And so, I think from my perspective, like anything, if you're thinking about it, then it's easier to diagnose it and easier not to miss it. And I think it can be such an easy thing to treat in a sense in the hospital. So there have been some studies, actually, quite a few trials looking at treatment of cannabis withdrawal. There have been some antidepressants that have been looked at, and nothing has shown good effect aside from mirtazapine, which might help with insomnia and appetite, but actually has no effect on cravings or rates of relapse. They've looked at baclofen, which can be helpful with cravings, but worsened sleep and cognitive performance. Gabapentin actually can be really helpful. That's one that I'll occasionally use, depending on what else is going on. In particular, this one trial found that it was helpful for improvement in cravings, withdrawal, and executive functioning. Quetiapine is the only antipsychotic that I found studied, but it does, another trial, was found to be significantly associated with reduced cannabis withdrawal symptoms, generally compared to placebo. And interestingly, though, it did not improve sleep, which I was surprised by. Zolpidem you can use to sleep as well as sleep architecture, which side note, cannabis, like we mentioned earlier, it can help treat REM sleep behavior disorders. And part of that is because it actually uh, re- it increases time to REM sleep as well as reduces the actual time of REM sleep. And so it can be really helpful for those behaviors in the short term. You can imagine how important REM sleep is for memory and learning and just feeling not fatigued the next day. So that's where zolpidem can come in and be helpful in particular. Guanfacine has also been looked at for irritability and improved sleep. I actually really like guanfacine in the hospital, especially because I do see a lot of patients with significant trauma histories who have exacerbation of hypervigilance and hyperarousal in the hospital. So it's a nice go to. There is some more evidence looking at NAC and topiramate more long term for cravings, especially in adolescents. And then, given the benefit of agonist replacement therapy in other conditions, right, like opioid use disorders, alcohol use disorder, there has been a lot of focus and research on CB1 receptor agonists like dronabinol, which we mentioned earlier. And that has actually been found to be associated with decreased cravings, increased appetite, improved mood, and decreased tension in three separate studies. So they found that it works in a dose dependent fashion. And so, what I'll often actually start with dronabinol. The biggest issue that I see is people underdose. So, generally, you want to start at minimum with a dose of 10 milligrams 3 times a day. And often what I'll see is like 2.5 scheduled twice daily, because those are often the doses we'll use before, say, like lunch and dinner in patients struggling with appetite who have cancer. For cannabis withdrawal, you need to get up there with the doses. So start with 10 3 times a day, and don't be afraid to increase that dose quickly based on withdrawal symptoms. And then I'll oftentimes adjunct too with these other meds that I mentioned, like the guanfacine, the mirtazapine, quetiapine, based on other medical and psychiatric diagnoses or symptoms, and trying to, kind of theoretically hit multiple birds with one medication while they're in the hospital.
It's for all the psychiatrists and everybody else listening, is like, get your template ready of like how optimize your template for how to do a substance use history. And like, I
Right.
think what you're talking about, it was like the right way to do it, like what they're using, how they're using it, how much, how often,
Mhm.
and especially last use, whether again, like it's the week
Right.
before, or it's, in the waiting room right before, or the
Yeah.
bathroom right before the appointment. Because that happened to me somewhat recently, where I shared the bathroom. I was like, I smell something in here that shouldn't be here in this bathroom.
Exactly.
And then now I see you in my office. I was like, I know what's going on here. So that
Yeah.
happens.
Yeah. And actually, really something to always consider if your patient has a mental status change that maybe lasts for a few hours in the hospital. Super common for patient to take edibles, vape in the bathrooms in their hospital rooms, right? Like family members will bring it in, or they just have it in their belongings. So always have substance use on your radar for patients, even if they've been admitted for weeks to months.
Tell us a little bit about, I know people are familiar with cannabis hyperemesis syndrome. They're familiar with the term, but can you tell us a little bit about that as a whole?
Yeah, I think of actually some of my residents will ask me, wow, why do you know so much about cannabis hyperemesis syndrome? You're a CL doctor. This doesn't make much sense. But I think that we actually get consulted a lot for these patients. So, backtracking a little bit, cannabis hyperemesis syndrome was only first described in 2004. So, it's actually a really new diagnosis, really recent. And like I mentioned earlier, translation to practice takes time. Really, it's defined as symptoms of cyclical vomiting related to high dose cannabis use that's associated with compulsive use of hot baths and showers to control symptoms, which I'll expand upon in a minute. They do have something called the Rome diagnostic criteria that was updated within, I think, the last few years that requires symptoms to be present for at least 3 months. Episodes tend to last under a week. You have to have at least 3 episodes in the past year, and there should not be vomiting in between episodes. So you pretty much return back to normal functioning between episodes. A lot of these patients are young and healthy, and they'll just show up to the ER during an acute episode while they're in the emergency department, as long as the workup doesn't show any, severe infectious, emergent etiologies. The doc will be like, okay, nothing severe going on, get some rest, drink some fluids, come back if these things happen. And because they get back to feeling better within a few days, these patients often don't show up to their PCP to try to get a diagnosis. So one of the issues with cannabis hyperemesis syndrome is that there's a super long delay in diagnosis. 5 to 10 years for a lot of people going through this, which you can imagine is a long time to be suffering with chronic intermittent nausea. And the description of cannabis hyperemesis syndrome probably sounds familiar. It's really similar to cyclical vomiting syndrome. Some people actually consider it as a subtype of cyclical vomiting syndrome, but where we know the exposure and the actual etiology and cause of it. So patients are often initially diagnosed with cyclical vomiting syndrome. And if you're not thinking about it, you're not going to ask about cannabis use. But when you are taking a history, when it comes to cannabis hyperemesis syndrome, 90% of patients in one large study actually reported improvement with hot showers and their symptoms. That is a very specific feature of this diagnosis. Always include it when you have cannabis hyperemesis on your radar, because that is really, really specific to this diagnosis.
And then the other part too, so let's talk about, you mentioned before kind of the correlation versus causation with
Mm,
cannabis, and it's this hot button topic. I think, I don't know if we're ever going to
yeah,
get like a real true answer on it, but schizophreniform psychosis, psychotic spectrum
right,
disorders, and cannabis use, again, correlation and causation. We know that there is a correlation there that is undeniable. Is it causing it?
right.
That's TBD, but can you expound on that a bit?
Yeah, I mean, I think you raise really the three big questions that I think we have when we're looking at this is one, does cannabis directly cause schizophrenia? Two, are individuals with schizophrenia more likely to use cannabis to self medicate? Or three, does cannabis increase the risk for development of psychosis in someone with genetic predisposition, right? So I think those are the three questions that I have when it comes to the research. I think the challenging part is that psychiatric research, especially for rarer outcomes, it's expensive, it's time consuming. And then you have ethical implications of giving people THC in a randomized controlled trial and seeing if they develop a psychotic disorder, right? So most of our information at this point is based on epidemiologic studies. These are really helpful, like you mentioned, for determining association, but less indicative of causation. So it can be challenging because there are so many confounding factors. More recently, because of the increased prevalence of cannabis access, use, these changing formulations, there has been a lot of research in psychiatry looking at cannabis use and risk for specific symptoms and diagnoses, with psychosis, I think, being the one that's been most heavily examined. A few things that I think stand out to me based on the research. One, it's well established that intoxication with cannabis can lead to psychotic symptoms while intoxicated, right? And then there does seem to be a dose dependent nature to that. So we do have some more kind of prospective or retrospective studies that look more at this kind of causation question. They found that more frequent high potency use is associated with increased risk for development of psychotic symptoms. And by more frequent use, I'm talking at least weekly, more likely daily. There was, in this one study that I examined, there was no association with risk for development of schizophrenia or psychosis in patients who used more recreationally, say once a month or a couple of times a year. So I think at this point, my takeaway as a psychiatrist is that I don't know if it directly causes schizophrenia, but I do think that there's enough information that tells me that exposure, especially in people with a genetic predisposition, increases the risk for development of schizophrenia. And again, would they have developed schizophrenia regardless? It's hard to say because we don't have, this kind of alternate world where we can do the exposure and not do the exposure. But I have enough data to say that that population in particular, people with a family history, particularly adolescent brains, that I'm really, really concerned about. And I think that the adolescent piece, as a child and adolescent psychiatrist, you are well aware of this, is so important. So, something to keep in mind is that CB1 receptors, which are part of our endogenous cannabinoid system, are really critical both during fetal development, but again, actually during synaptic pruning in adolescence. And because of this activity, it's important for development of learning, for neurodevelopment, and we've found that people who have chronic exposure to CBD have downregulation of CB1 receptors during this critical neurodevelopmental time, which has been associated to adverse outcomes in things like learning, occupational functioning, as well as even more long term IQ issues. And on top of that, that is probably a time that's incredibly important in the development of schizophrenia.
Yeah, I like you mentioned, I when my teens patient comes in there, I always tell him, I was like, you know, if we're having this discussion 10 years from now, it's a different story, right? Like, but right now, I always tell you guys,
Right.
it's like try to avoid it right now, try to avoid like the heavy use right now, because your
Yeah.
brain is going through those changes and your risks are there. Again, I can't say for sure that this is what is going to cause you to become a psychotic, but
Exactly.
we know that there is a relationship that exists, an association I believe exists that we can't argue with, really.
Yeah, and I think like anything in medicine that does have such like polygenetic risk factors, you want to think about environmental exposures. What can I reduce environmentally to at least reduce the risk of someone developing, say, this cancer, this autoimmune disease? Same thing with schizophrenia. How can we reduce those environmental insults so that someone has the best chance of having this healthy, productive life?
Yeah. On the opposite spectrum from like our teens and adolescents, we have like delirium, and then also, I mean,
Yeah.
catatonia also pops in here and there. But like, let's talk about delirium and catatonia because I think that's something that a lot of people don't always talk about with cannabis. They don't always associate it with that.
Yeah. So, with catatonia and delirium, I most of us as healthcare clinicians, we work through illness scripts. These illness scripts are developed over time through experience and attained knowledge. It's a wonderful framework that allows us skills that are beyond what a Google search or even these large language models can reproduce. But sometimes our scripts can actually contribute to anchoring and confirmation bias. So, again, I sound like a parrot here. Cannabis has changed so much in the last 15 years. So if we sort of grew up in this time of medicine where we learned about delirium and catatonia, let's say in the early 2000s and the 90s, it was not something that was clearly associated. But when I did a literature review, what I found was really in the past 15 years, people are starting to write up case reports and case series. Yeah, it's not the most robust kind of evidence base, but I do wonder how that might be in relation to the increasing potency of cannabis. So, for example, let me see if I can find it here. So, there was a really comprehensive literature review that actually, sorry, we might have to backtrack. Oh, I found it. Okay. I don't know if we could just edit that part out. Okay. So I did find there was a comprehensive literature review published in 2024, and they identified 26 cases, so case studies or case series of catatonia associated with cannabis or synthetic cannabis use. Out of these cases, 84% were male, aged 15 to 36. 11 had a history of synthetic cannabis use, 15 with recreational or medical use. Interestingly, in the majority of these cases, they did a Naranjo score and determined that the cannabis was the most likely etiology of the catatonia. And very few of these cases had any psychiatric history. And so when I think about synthetic cannabis in particular, we know that it's quite potent and it really binds strongly to the CB1 and CB2 receptors. And so when we compare that to these changing concentrations and potencies of cannabis in these modern strains and concentrations, I have to ask the question, is modern cannabis more similar to these synthetic cannabinoids in some sense than it is to the traditional formulations of cannabis that we were using prior to 20, 30 years ago? And if that's the case, then I have a feeling we're going to see more cases of catatonia associated with cannabis and cannabis withdrawal.
Yeah, I agree. I mean, I always kind of say when I'm talking, teaching to like the residents and everything and people online is like dose makes the difference, right?
Right,
What's,
exactly.
like the difference between like Disoxin, methamphetamine that you pick up at the pharmacy versus
Yeah.
methamphetamine that you buy in the streets is dose, right? Like
Lith-
that's
Look at lithium.
yeah, lithium, right? Again, lithium orotate that like people are like using as a supplement to like,
Mhm.
balance
Yeah,
their mood out versus, lithium toxicity. Like again, this
right.
is the dose makes a difference with everything. And it's the same with cannabis, alcohol, etc. Everything that's there. So
Yeah,
good.
and I think one the way I like to approach these, because I think especially this is the case in CL in academic centers, we see some weird stuff, less common, rare things, and I always try to take a step back and think about, okay, what is the possible underlying pathophysiology that's happening here? Does this make sense conceptually in a logical sense? And so, we do know that THC can actually increase the brain's levels of GABA and decrease glutamate. And so abrupt cessation from THC can actually put both of those neurotransmitters out of balance and theoretically develop catatonia. THC also impacts NMDA receptor activity, right? So again, that's something that we see in catatonic syndromes. It's part of our treatments. So I think if the theory makes sense, that it might be worth considering it and at least looking into data, starting with case series, case studies, collecting that, and then going to higher levels of evidence.
And another part that we have to like understand and realize is that like THC, CBD, cannabis as a whole, like doesn't always play well with our medications, correct?
Oh yeah. Oh, definitely. Yeah, I think this was one of my biggest takeaways, actually, kind of going through and putting this paper together. So we talked a lot about sort of the brain and the function of cannabis on different receptors. But one thing that's really important for psychiatrists and really any medical provider that's prescribing medications are going to be metabolism and drug interactions. So these usually occur through the CYP enzymes. So a 2024 study actually found that most drug classes have the potential to interact with cannabis through CYP enzyme reactions. So THC is metabolized by CYP2C9 and CYP3A4. And it also acts as a competitive inhibitor for a bunch of other CYP enzymes. And then, similar to cigarette smoking, smoking cannabis can produce these polycyclic aromatic hydrocarbons that then induce CYP1A2 enzyme. So that can impact the metabolism of a ton of different medications, including of course, clozapine. So these different CYP interactions can then affect serum levels, both of the drugs, as well as cannabis itself. And I think we have to keep in mind too, THC is super lipophilic, so it stores in the fat for a very long time and can continue to leach out well after cessation. So you really want to think about interactions with cannabis like weeks to maybe a month or two after someone discontinues usage.
Yeah, it's for all the med students who may be listening, it's another thing to add to those charts around the CYP enzymes
Right.
that we have to remember. And just again, as it becomes more and more prevalent, we have to be aware that it's going to interact. And I think we see it a lot of times when parents come in again from to my office and they ask like, can the kids smoke on this or use this while they're
Yeah.
taking some of their SSRIs? And it's like, ideally not, but like we have to be realistic and understand that it's going to
Right.
happen and the effects that can occur with them. So
Exactly. And I think it's interesting. It's something that comes up a lot in transplant evaluations, and not just because of the direct effects of cannabis and smoking on whatever organ systems involved, but because of the interactions with a lot of the transplant medications themselves.
yeah, and seizure meds too, right?
Yeah,
Huge with
yeah, that's a
seizure
huge
meds,
one.
and especially with like the investigations of or THC in
Mhm.
seizure medication as an anti-epileptic itself. That's something we just have to be aware of as well.
Right. Exactly. And valproic acid, which
Hmm.
is a very common med in psychiatry.
Yeah. Do we, as we kind of like wrap it up a bit, like stigma? I know we're again like we're the
Mhm.
article kind of gives that little disclaimer, kind of like then that
Yeah.
we're talking in the negatives about it, but like as we kind of like talk about that, how do we avoid recreating stigma around cannabis so that
Yeah.
our patients can be honest and we can help them the best? Because honesty is the best policy, and we want our patients to let us know what's going on so we can help them the best, and we have the most information to do so. How could we just kind of say like, let's not stigmatize this and shame on you for using this, and this is what happens if you do it?
Right. I know I actually even struggled in, thinking about submitting this article for publication or even coming on this podcast and talking about it. I am talking about all these negative impacts in the medical setting. How might that contribute to stigma, right? I don't want to be harmful in that way. So, I think the big thing again is taking that step back and remembering that life has so much nuance and gray in it. And in particular when it comes to even our medications we use, right? I mean, there are risks and benefits of so many meds, especially in psychiatry. I almost take the same perspective on cannabis. What is the reason that someone's using the cannabis? Having that very non judgmental approach with the patients, but also not feeling that internalized stigma myself, right? So if I'm tiptoeing around the cannabis use, I'm not normalizing it, right? And I'm making them feel judged in a way where it's this kind of dirty topic that we're talking about versus me just kind of outright asking about it it in kind of a normal manner, using language that people often use in the community, and not trying to over medicalize everything. So I think coming at it from that very judgmental, motivational interviewing perspective, right? Trying to discover what is it about cannabis that keeps you going to it. What is it helpful for? What do you like about it? How is it impacting your life in a negative way? And having the patient tell you and kind of come up with that and really say it out loud to themselves is really important. And then again, I think all we can really do as psychiatric providers is try to stay as up to date on this very evolving um, wide breadth of literature on this topic and do the best we can to be a good consultant to our patients and give them as much information that's not biased on the risk and benefits so that they can make that well-informed decision on their own. But
Yeah.
yeah, never shame someone for anything
Yeah.
like that.
No,
That's a good takeaway.
yeah, I'm glad to hear that like we've got that overlapping in regards to how we're asking the questions of like what's it doing for you? Like, and just
Yeah,
kind of like you ask that question a lot of times when you lead with that question of like, instead of saying why are you using it, saying,
right.
what's it doing for you? What are you getting from it positively?
Yeah,
That changes the whole tone of the conversation and allows hopefully openness, and then again being able to synthesize that information and come up with whatever treatments or helps that they're looking for, and just understanding that part of it. So
yeah, exactly.
wrapping up again, big picture, what are you hoping after like reading this article, listening to this podcast, what do you hope that psychiatrists, trainees, doctors as a whole, society maybe, what do they get
Yeah.
from this?
I think the big takeaway, honestly, is coming down to that whole conversation about dose and, what is the actual specific compound. So I think that remembering cannabis as a word can mean so many different things, right? It can mean sort of traditional 4% flower, or it can mean this 90% concentrate. And those two substances are completely different and have totally different effects on the body. So, really getting down and asking someone, what are you using? How much of it? When? What's the frequency, right? What's the route of utilization? I think that thinking of it in terms of dosing is really key to help us from there extrapolate, okay, is this actually kind of a concerning dose and formulation? If so, then we can go down this route of education, working on it, versus maybe it's something that they're using infrequently, like once a month recreationally, and it's having no adverse effects, right? So I think that's probably my biggest takeaway. And then number two would just be to remember that if you're not thinking about it, you're not going to ask about it and you're not going to diagnose it, right? So having this index of suspicion for cannabis being related to different issues, whether it's anxiety, insomnia, catatonia, vomiting cyclically, all of these different conditions that can be related to heavy cannabis use, especially as it becomes more and more common as it's recreationally legalized. I think we're only going to be seeing more of these conditions. So as long as it's on your mind, on your radar, and you're asking about it, then everything kind of works out from there in terms of identification.
Yeah. And I always kind of like to ask our guests on here, Dr. Murray, what do you like to do for your own self care before just, we have to, as we want to make sure that we have psychiatrists are around for a long, long time. So, yeah.
Oh, I love that question. I have gotten super into native plant gardening, which I always joke that gardening in Denver is on hard mode because our weather is so extreme here. And we probably only get about 5 months of real flowering gardening weather. But I've been slowly replacing my entire yard with natives. And this season, especially, have noticed so many more birds and pollinators that I am just delighted. So
Nice.
that has been my major self care the last couple of years.
Awesome. 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 Well, thank you so much, Dr. Murray, for joining us on this very, very relevant and topical topic.
Of
uh,
course.
um, so this was our podcast for the month of June. You can find it online, psychiatryonline.org. Again, the article is Clinical Considerations of Cannabis Use in the Inpatient Medical Setting. Please follow along with the podcast, subscribe on iTunes or whatever the podcast apps are. Give us a like, comments, and let us know what you'd like to see and hear in the future. And thank you again for joining us.
Thank you.